all. I invite Dr. Prasenjit for the next session, and it's on should all the gallbladders removed for gallstone be sent for the histopathological examination and histopathology of gallbladder. Dr. Prasenjit, he is a professor in pathology at AIIMS Delhi.
So, good afternoon everyone, and welcome back after the lunch. And at the outset, I just want to say thanks to Professor Kapoor and his team for inviting us. And I think this is a burning topic as we are discussing from the morning, what should be done, how to suspect the tumors, and what is the importance of histology. And these are the questions I am going to cover. There are 4 sub-questions. The question 1 would be, should all gallbladders removed for gallstones be sent for histopathological examination? My answer is yes, all cholecystectomies performed for gallstones should undergo histological examination to rule out incidental gallbladder carcinomas, and here are the evidences. All these discussions I am hearing since the morning, possibly highlighting one of the fact that the Dutch group, they did a very nice study, and they said selective histological examination is sufficient for gallbladder examination. And they said because incidental gallbladder carcinoma incidence is very low, hence is it justifiable to do histopathological examination in all cases of gallbladder. And even if there is a TIS or T1A lesion, a simple cholecystectomy should be sufficient, and up to 10-15% of all histological macroscopically atypical gallbladders show microscopic abnormalities. But there are other aspects. If you don't do histological examinations, because as we are discussing from the morning, what are the challenges the surgeons on table and preclinical level they face to identify which one is gallbladder carcinoma. So are we leaving the patient to assumptions? And please remember, not all IAS or T1A tumors have gross changes, because of the simple fact that now we know very clearly that gallbladder carcinoma has 2 different pathological origin. One is from the papillary dysplasia, which is we call as ICPN, and other is flat dysplasia, which call built-in. Hence, all August gathering in this hall can say which one of them perineoplastic lesion will show you macroscopical abnormality in the gallbladder wall. Hence, it will be an assumption to see, to think that this patient will not have a perineoplastic lesion or an early invasive gallbladder cancer. And see at this Malaysian study, they showed that T1B and even in T2 in invasive gallbladder carcinomas, they did not have any documented macroscopic abnormalities. Bosch et al. Did a very large study, nearly about 7,000 cholecystectomies, and these proportions of neoplastic and invasive gallbladder are in sync with others. And see, this is most important, in only 0.5% of these neoplastic and perineoplastic lesions, they could identify macroscopic abnormality during naked eye examination in the operative theater. Renzo et al., another, they examined 16,000 gallbladder resections, and they identified nearly about 9 high-grade dysplasias, but there was not a single case which showed gross abnormalities of the gallbladder mucosa. We know there are many studies has been done from the Chile, and ROA group is one of them. And in their 2 separate studies, they also said they could not identify any macroscopic abnormality or naked eye examination in about 30 to 60% cases of invasive gallbladder carcinomas respectively. Hence, not recommending the histopathological examination will be non-diagnosis we are offering to the patient in up to 30 to 60% cases. Hence, there will be deprivation of the re-resection and other oncosurgical excision. This is a simple example how the selective histological examination protocol failed. The Dutch group make a nationwide protocols and they said this should be followed in all hospitals in this country, the selective histological approach. However, it was found in 2021 only 47% of all hospitals in the Netherlands, they followed the protocol. Hence, this shows that there is a question even among the surgeons, and all gallbladder should be examined. I'm hearing a lot of assumptions and assertions about the frozen section examination during the gallbladder surgery, and frozen section is a very good modality. But please remember, not in all cases frozen section interpretation is very easy because of high inflammation, fibrosis in the gallbladder wall, and it will be very difficult to identify in TIS or T1A lesions in frozen section especially. And most of the literature what you see about the sensitivity and specificity, those are from the tertiary care centers, and they often don't mention about the early stage gallbladder carcinoma which was identified on the frozen section examination. There is another fact, we all know that there is a marked difference in the survival described from the European countries, which is 5-year survival of about 30% versus 10-year survival of about 90% from the Chile. And this was primarily because of the sampling and histopathological examination and further management course of the gallbladder. Hence, in all countries with a high prevalence of gallbladder carcinoma, histological examination of all resected gallbladder for the gallbladder stone is must. My second question was, should the cystic duct be marked in all gallbladder specimens sent for histopathology? My answer is yes, cystic pedicle margin should be marked in gallbladder specimen, because we all know a positive cystic duct margin not only increase the PNI, LVI, and when the cystic duct margin is involved, the CBD involvement chance is almost, it is around 40% versus when the cystic duct is free, it is about 4%. And, but what is the state? There is not many studies which are available who have done this kind of survey, but the Dutch group survey says that when they evaluated their nationwide reports and found that cystic duct margin status was mentioned only about in 77% of the tumor, and the distance from the tumor and cystic duct margin was mentioned only in about 10% cases. Hence, somewhere we are failing, and pathologists are not mentioning or sampling the cystic duct margin status. Why? Either they are not aware, or they are grossly disfigured and calcified, and as someone mentioned, all gallbladders must be open in the OT, and that should be a protocol. That also make us our job difficult, which one is actually the actual cystic duct margins. Hence, it is important when you are opening a gallbladder in the operation theatre, you should mark with a water resistant dye or put a suture mark so that the pathologists know this is the margin I have to sample and put in face. My last two questions are three sections from the fundus, body and neck of the gallbladder are enough for histological examination? If no, should a complete histopathological mapping of the gallbladder be done in every case of gallbladder carcinoma? The answer, first one, is yes, but there is a modification. How we are taking these three samples from three vital areas of the gallbladder, it should be continuous longitudinal sections including the fundus, body and neck of gallbladder, plus the in-face sampling of the cystic duct as we discussed, and this should be enough when the gallbladder is macroscopically normal. However, if you have identified something at the OT, opened up the gallbladder, there is a macroscopic additional lesion, then this 3+1 protocol along with all those areas where there is thickening, asymmetrical thickening or small bump in the mucosa, those should be additionally sampled. We know this evidence that if we if we do only macroscopically guided histological sampling, possibly we are missing 70% of the TIS or T1 means early stage gallbladder carcinoma, and up to 1/3 of T2 lesions or above even will miss if we not do histology in all. But what is sufficient sample? I will quote this beautiful study by the Duet et al. They compared three protocols. The first one, they took one sample from the fundus of the gallbladder. Next one, they took one longitudinal section and divided into three-part fundus, body and neck. In addition, they took cystic duct margin, and they also compared the sample the whole gallbladder and mapped the whole gallbladder. And they found that if we are only taking 3+1 sampling method, then also we may be missing 65% of the neoplastic lesions in comparison to the whole gallbladder mucosa sampling, that is the gold standard, and when only one random sampling technique is followed, then possibly we are missing 85% of the neoplastic and pre-neoplastic lesions. There is another nice study by the Argan et al. They also compared if the metaplastic changes, dysplasia and incidental gallbladder carcinoma differ in these two protocols. One is longitudinal sectioning, including the whole gallbladder mucosa, and 3 random sectioning, and they found that all these changes are much more in the cases where one longitudinal strip was taken and divided into 3 parts. This simply says that we are covering more mucosal volume, then we will be identifying the neoplastic lesions more. Because we should know that while it has been seen in this kind of study where the whole gallbladder mucosa was mapped and sampled, the metaplasia is usually in average involved 25% of the gallbladder mucosa, hyperplasia similarly, and when the dysplasia and invasive carcinoma occurs, then their area of involvement is very limited. Hence, more the number of sample or strips we are taking, we will be identifying more neoplasia. But the question is, what should be the responsible sampling, and if we can follow a step sampling method. There is one study which showed that one longitudinal sectioning protocol of the gallbladder, what we already discussed, was identified in the initial sections. But in this also, though the neoplastic lesions were identified, after taking more sample in the second step procedure, they identified that the deepest part of the gallbladder carcinoma, or for the staging purpose, there was some discrepancy when they only relied on this one longitudinal sectioning protocol. And Renshaw et al., already I have mentioned, they studied 6,000 cholecystectomies. They identified 106 atypical mucosal lesions in the initial random sampling. Then they took 4 additional mucosal samples, and they found that in them they could further identify 16 low-grade dysplasias and 9 high-grade dysplasias. There was, from these studies or from these publications, the people take a cue, and they published a protocol in 2005. That current protocol strongly recommends that the whole residual gallbladder mucosal mapping when a high-grade dysplasia or polypoidal dysplasia is identified. However, the Bosch et al. In subsequent studies found that though they have taken initial 6 to 8 additional sectioning after identifying high-grade and low-grade dysplasia, only they could identify incidental gallbladder carcinoma in 10% of the cases which showed high-grade dysplasia, and there was no invasive carcinoma in case of low-grade dysplasia. There was another study who also, after taking additional sectioning, could not identify no further difference in the dysplastic lesions or invasive carcinoma. Reyes et al. Also, this is the group from the Chile, they also took additional section, as well as they took sampled some entire mapping of the gallbladder, and they also found no additional lesions in their gallbladder. Hence, it is clear rationalization is needed. Hence, my last slide is like that. If macroscopically normal gallbladder you have sent from the OT, 3 continuous longitudinal section like this should be sufficient, including the cystic duct margin. However, if there is a macroscopically abnormal gallbladder lesion or gallbladder, then 3+1 additional sections as per the macroscopical abnormal areas must be taken. When high-grade biliary intraepithelial lesion identified, then additional 6 sections and we can just put 3 longitudinal sections in one block, so it will add only 2 blocks to our workload. That is not very high, and if there is no further lesion identified, then in a high incidence area further whole gallbladder mucosal mapping can be done, but it should be at per discretion of the institutional protocol or the pathologist. If the gallbladder showing intestinal metaplasia or low-grade dysplasia, additional 6 sections must be taken to see if there is any high-grade dysplasia or incidental gallbladder carcinoma. If there is no further lesion, no further action should be done. Gallbladder showing incidental gallbladder carcinoma on the initial section, 6 further sections must be taken. This is for accurate staging and identifying the deepest part of the tumor. And if there is polypoidal dysplasia, the whole polyp must be examined, and additional 6 sections from the adjacent area should be taken to see if there is any other additional mucosal lesion into the adjacent area. So with that, I will leave it to the comment, and thank you so much for inviting me.
Thank you, sir. Now I am calling for the comments. Dr. Isidoro Di Cario from the Italy and Dr. Puja Sakhuja.
All right, all is perfect. Ladies and gentlemen, thank you very much for your kind invitation. First of all, let me to apologize. I'm Italian, so I do not speak well English, your language, so I hope you will understand. First of all, I would like to thank Professor that invited me, and it is for me a great honor to be there. It's my 5th time in India. It's a fantastic country, and I visited several cities, but it's the most important historical city, in my opinion. So it given me this opportunity to talk about if we have to do examination or histopathology after cholecystectomy or not. So as you see from this image, India and Chile are the most important, impressive country in which this has become a problem, and especially in northeast India, this is a great problem that you have to examine it day by day. So what is the risk factor for the gallbladder? Why we have to ask to ourselves if we have to do examination by histopathology or not? So gallstone disease is the first, so the age. But remember that a gallbladder cancer in young girl have been reported in the literature. We have tuberculosis, especially in some country like Asia, become a problem. And of course, female sex due to hormones. Everybody knows this. But last we have obesity that become a great problem, especially in Europe and United States. And is a factor that is not depending from the other factors, so have to be analyzed very well. After we have other factors, especially in Asia, there's a common aflatoxin, for example. Probably the majority of you do not know that the country that produces pistachio in the world is Afghanistan, and the majority of pistachio in Afghanistan is affected by aflatoxin, and this is a big problem. We eat pistachio, we don't know, and we have this problem with us. How to do the examination when we have this problem? So all this possibility, we can use whatever you like, whatever you want, whatever you have in your hospital. You can do also biopsy by a fine needle aspiration in presence of mass, or you can drain fluid if in case in which you have some cholecystostomy. This happens. But sometimes the examination, as you said this morning, is by self-surgeon examination. I think has to be avoided, because sometimes if you have a TA or TB tumor, you are not able to do right diagnosis. So also if you have wall thickening, mucosal ulceration, and all the factors, it's much better to send it to pathologist to do the correct examination. It's very difficult to pre-operatively to do diagnosis. So because if you have a cholecystitis, it becomes very, very difficult. This is our study that have been published on World Junior Emergency Surgery. In case of cholecystitis, we do a subtotal cholecystectomy. We have 4 types, and we can apply what is the best for us. This is translated also for cancer. But when you have a cancer and you leave the infundibulum on the body of the patient, you have the risk to leave also the cancer. So for this reason, I have a new technique that I have to show today, and as the following, right, is commented. Can you put it there? Sorry, there is just a little bit patience because I have to put the. Is here. Yeah. Right. Look at the volume, please.
The gallbladder is completely covered by the grey is subsequently electrocauterized. Extraction of the gallbladder, cleaning of the cavity and positioning of a suction drainage is done.
Right. This has been a procedure
The
that.
gallbladder is
Sorry, this is a procedure that I pointed out for inflammation of the gallbladder, as you understand. But this can use it also for cancer because it permits to avoid the total cholecystectomy. In the opposite, you have to do subtotal cholecystectomy in a part of gallbladder remain in the abdomen. So just to think what we can do if it's useful for us or not. So continue my exposure. We have a survival if do early diagnosis, but to do early diagnosis, we have to have all gallbladder, of course. And if you analyze histopathology, yes or not, you see that the majority of authors coming from India said that probably there is an amount of a disease that is not diagnosed before. Also, in this case, we have almost 200 cases is not diagnosis. And when people from Netherlands try to do if some surgeon prefer to do diagnosis or not, there is equity in this problem. So there is a problem of cost, of course. In Turkey is less expensive European country is 60 euros per pathological examination. This is a diagram that has been done by Professor Kapoor. It's very, very interesting because it's the complete algorithm that you can find in the literature that analyze all the cases and what you have to do in a difficult situation. So my conclusion is this. So probably histopathology examination for us as Italian is mandatory. I explain you why. There is a 3 countries in the world in which there is a penal prosecution if you have a problem with the patients with no diagnosis of cancer. It's Mexico, Poland, and Italy. So if you have a problem, no diagnosis, the cancer, and the patients come back 5 years ago, send you, I have the cancer, but you know, do the gallbladder to pathological examination, you go in the jail. There is no solution. Is it true? Oh, if you do not go in the jail, you have spent millions of euros. So this is another problem. So this is the reason why probably my conclusion is not considered all over the world. By now, country is mandatory to do this. Right, this is the literature that analyze, and I have to conclude with a simple question. And if somebody would like to ask, I would be more than happy to have the answer. If the gallbladder is your, what you do? Thank you very much.
Dr. Puja Shukla.
So I'd like to thank Dr. Vinay Kapoor for inviting me here. It's very interesting to discuss these problems, and it's even more interesting to hear all the surgical issues, because that's something we don't hear every day, and that often has a pathological aspect. So it's nice to hear the discussions there too. So I'll be answering I'll be commenting on the question 7, as Dr. Carlos has commented on question 6. So now I've put this in red, my answers, because this is not necessarily an all or none question, and a lot of it depends on whether you're in a high risk area or a low risk area. So though yes, 3 sections from fundus, body and neck are usually sufficient, but that may be true more in a low risk area. And in a high risk area, it may not be sufficient to, not give enough sections of the gallbladder, because you do not want to miss any gallbladder cancer. And one of the articles which Prasenjit has also referred to shows how where fewer sections are taken, the 5-year survival rate is in fact lower than in countries where more number of sections are taken, because of the fact that there is increased sampling. You can catch the cancers in time and adequate treatment can be given. So although the usual section, as Prasenjit also showed, is to take the cystic duct margin and then one continuous longitudinal section which you divide into neck, fundus and body, and process it accordingly, neck, body and fundus, and process it accordingly. However, in a high risk area, if without increasing the number of blocks, you can put a few extra sections from the neck, body and fundus into the same block, then that would be advisable, because you're not really increasing the workload of the pathologist or the path technical staff, and yet you are covering more volume, which was what was explained by Prasenjit also, which is very essential. The more volume you are covering, or surface of the gallbladder mucosa you are seeing, the more likely you are to pick up any atypical epithelial lesions. Of course, if there is any suspicious area, extra sections are taken. Also, it's important to check the contents of that container, because sometimes a small polyp or mucosal region which is necrotic may fall into the container, and so the contents which you think are just debris, stone, sludge must be checked once to see that there is no mucosal substance in that. That's for the pathologist, of course. The reason being, now the other thing that we always explain to all our pathology residents the moment they start grossing gallbladders is that don't just look, feel, palpate the entire gallbladder specimen, because the flat dysplasia is often not macroscopically visible. Yes, it may not even be visible to palpable, but often if you see a small area which is firmer, it may be thicker, firmer, more granular to touch, then that area must be sampled, as that area is definitely suspicious. So now the recommendations, which I'll summarize in the end, but just to take you through these. If you see in a gallbladder pseudopyloric or antral metaplasia, it's very commonplace, we don't need to do anything extra. However, if we see intestinal metaplasia or dysplasia, without dysplasia, since intestinal metaplasia is known to occur more frequently in cases where there is gallbladder cancer, it is advisable to take at least a few more sections to rule out any dysplastic lesion. If we see low-grade dysplasia and or reactive atypia, where you're not sure whether it's low-grade dysplasia or reactive atypia, again, now the larger number of blocks, I've put slashes, because the higher number of blocks may be advisable in a high-risk area and the lower number of blocks in a low-risk area. So you take a few extra sections from the gallbladder then. In a high-grade dysplasia, in a low-risk area, you may take just a few extra blocks, but in a high-risk area, it is better to whole process the entire tissue. Again, there are adenomyomatous nodules where the mucosal glands have dipped along with the muscle into the lower muscle or even the perimuscular tissue. They can be identified as adenomyomatous nodule. If there's any suspicion, a few extra blocks can be taken to rule out any malignancy. So in a pseudopyloric or antral metaplasia, no extra sections are required. Sometimes you get this sort of a polypoid appearance because of extensive pyloric metaplasia. And if these are not true polyps, but just polypoid appearance, less than 1 centimeter in size, again nothing more is to be done. If there is intestinal metaplasia or foveolar metaplasia, which is different from pseudopyloric, it occurs on the surface. Now in these two conditions, a few extra blocks should be taken. The panel on your left is intestinal metaplasia and the one on your right is superficial foveolar, gastric foveolar type of mucosa, which is foveolar metaplasia. Now low-grade dysplasia is when there is a clear-cut surface epithelial involvement in contrast to reactive atypia. So when there is surface epithelial involvement by crowding of nuclei, penicillate nuclei, overlapping of nuclei, it is low-grade dysplasia. These changes should not be limited to the crevices of the crypts, but in fact should be seen in the surface. In such cases, few more sections should be taken to rule out any high-grade dysplasia areas. In our institution, we allowed the pathologists to do whatever they wanted, more sections or whole process. So we found that when we took out a series of 85 retrospective disc cases and saw almost 50% had taken more sections and 50% had whole processed the gallbladder. And in these cases, only in one case, we saw a few cases which had high-grade dysplasia, but only in one case did we see an actual carcinoma in situ appearance, and that was a case in which it had been whole processed. However, still having said that, I think if you take a few more sections and it's still low-grade dysplasia, you don't need to do anything further. This is just to show you the difference between reactive atypia, which is a gradual transition often associated with some inflammatory cells, versus dysplasia, which has usually got an abrupt transition. Either way, if it's a low-grade dysplasia versus reactive atypia, you're going to take just a few more sections and look for any high-grade dysplasia. So this is an example from one of our cases. The low-grade dysplasia in the initial sections just showed few more foci of low-grade dysplasia in the more sections, but no area of high-grade dysplasia in this. And so that was of no further consequence and nothing more needed to be done. High-grade dysplasia, in our country at least, I would recommend to whole process the entire tissue, because we know that it is often multifocal or diffuse, and then one of those areas may harbor invasive malignancy. And also, let's not forget, this is a good research tool for biomarker development, and so if you can identify these areas, we may be able to develop a biomarker to be able to identify this in a preoperative setting as well. So in our study, when we were whole processing all the gallbladders with high-grade dysplasia, and 7% of them showed further lesions away more than high-grade dysplasia, with 5% having T1A and 2% having T1B or T2 lesions. So therefore, I've clubbed that, meaning that maybe in those cases further surgical management would be advised. So this is an example of a high-grade dysplasia, where you see a lot of nuclear crowding, overlapping, increased NC ratio, mitotic activity, etc., and it's often diffuse. And this was the one of the cases in which we saw T2 lesion, and we took I think it was around 30 more sections to whole process the entire gallbladder, and it was in the more section number 16 that we found the T2 invasion. In no other more section did we find this invasion, and therefore sometimes a stepwise approach in a high-risk area like ours may not be able to identify the full depth of invasion, and it's better to whole process the lesion. So which are the conditions where you would whole process? High-grade dysplasia or carcinoma in a high-risk area. High-grade dysplasia or carcinoma in situ, pancreaticobiliary maljunction because of the high propensity of risk of gallbladder cancer in these. If there is a polyp with dysplasia, you will whole process the polyp. Then take some more sections from the surrounding mucosa, and based on what you see there, you proceed. Then a hyalinizing or porcelain gallbladder, again at a high risk of carcinoma, and that too it is often not a papillary type of carcinoma, but a flat carcinoma, and therefore can be missed if you're taking only few sections. In ICPN, you will process again the entire carcinoma to maybe in a stepwise manner till you find the maximum depth of invasion. So in our experience, the number of more sections required to be able to find the maximum depth of invasion was ranged from 4 to 29. So a stepwise approach may or may not help. To summarize, this is sort of a flow chart. So if there's antral pseudopyloric metaplasia, nothing further. If there is intestinal foveolar metaplasia, take a few more sections. If it's still the same, nothing further. If you see low-grade dysplasia, then proceed as that indicates. So in low-grade dysplasia, we take a few more sections, 4 to 6 in a high-risk country. Again, if you see low-grade dysplasia, nothing further. If you see high-grade dysplasia or carcinoma in situ in these, then you process the whole tissue. And if you have a polyp, as I explained earlier, process the polyp whole and the surrounding gallbladder mucosa, take a few sections, and then based on what you saw, take it back to the same algorithm. Thank you.
I would like to call upon for online comments Mr. Nicolae from Romania and Mohammad from Bangladesh.
To Professor Kapoor. Hello and greetings from Bucharest, Romania. And thank you very much for having me at your prestigious Congress. And I would like to extend my thanks especially to Professor Kapoor. My name is Nicolae Bacalbasa. I'm the head of Department of Surgical Oncology at Fundeni Hospital in Bucharest, Romania, Eastern Europe. The topic today is whether we should send all the specimens of cholecystectomy to pathology. If you ask me, I believe we shouldn't, because the number of gallbladder cancer is very small, and they are in very incipient stages which do not require further treatment. So from an epidemiological standpoint, the effort of analyzing and the resources put into analyzing all these specimens of cholecystectomy is too big compared to the benefit we draw from this. However, I would like to tell you a genuine Romanian story, and also to tell you that in Romania it is compulsory to send every specimen you remove from a human body to pathology. So the question whether we should send them to pathology or not does not apply to Romania because of the law. On the other hand, I have a little story I would like to share with you about a fellow surgeon who performed a cholecystectomy to a nurse who worked in the same hospital. The nurse didn't come back to collect the pathology report, and the surgeon didn't look at the report. 2 months later, the patient started feeling bad, losing weight, and a CT scan showed metastasis in the liver. And of course, then they went back and they looked at the pathology report, and it was a gallbladder cancer. It was a T2. The patient went to a tertiary center to get chemotherapy and further treatment, but unfortunately she died 4 months later. And the family of the patient sued the doctor, and there was a first expertise which was conducted by a famous professor from Romania, professor of surgery, who concluded that in fact the surgeon was responsible to get the patient to collect the pathology report, and actually that it was the surgeon's fault. The second report was done by me, and the conclusion was that it was not the surgeon's responsibilities, but the patient's responsibility to come and collect the pathology report. But anyway, for the surgeon and for the patient, it was a big problem. The patient died. Of course, we can only wonder if her destiny, if the patient's destiny would have been different if she had started the treatment immediately after the surgery and the arrival of the pathology report. And anyway, it was a big trauma for the family and for the surgeon. And imagine what would have happened if no specimen would have been sent to pathology. So in view of these things, we should only we should balance carefully if at least in the countries who do not have a legislation such as Romania, at least a macroscopical examination should be performed, and in case of doubt, a microscopical examination should be performed. I thank you very much. I wish you a pleasant stay, and thank you for having me here. Thank you very much. And
I would like to call upon for online comments Mr. Mohammad Sowkat from Bangladesh.
Respected faculties and learned audience, good afternoon and have a good day. I am Dr. Sowkat from Bangladesh, working as pathologist in Armed Forces Institute of Pathology, which is located at Dhaka Cantonment. I feel honored to join this third JSF Surgical Festival through online, and I express my heartfelt thanks and gratitude to our respected Professor V.K. Kapoor sir for giving me the opportunity to say a few words in this august occasion. I was assigned to make a comment on the question number 6, and for that reason I have prepared a short presentation, and I welcome you all to my today's presentation. Ladies and gentlemen, all you know that all we are here to discuss about the various issues related with the gallbladder cancer, and our main emphasis is on incidental gallbladder cancer. The gallbladder cancer is the fifth most common cancer of gastrointestinal tract and most common malignancy of the biliary tract. India contributes about 10% of the global gallbladder cancer burden. This global map depicts the incidence of the gallbladder cancer across the various regions of the world. India is among the high incidence area for the gallbladder cancer, similar to the Latin American countries. 22 out of 1 lakh population having the incidence of gallbladder cancer in this region. Gallbladder cancer is highly insidious and notoriously inapparent both clinically and macroscopically, as because the more than 1/3 of the advanced gallbladder cancer, that is the T2 stage, and about 70% of the early gallbladder cancer are missed during the gross examination, even by an expert pathologist. And incidental gallbladder cancer is gallbladder cancer detected for the first time on the histopathological examination of the gallbladder specimen, which was not suspected even in imaging or by the surgeon during operation or by the pathologist during gross examination. So the aim of my presentation is to apprise you about the rationality of histopathological examination of all cholecystectomy specimen and literature review. My question was, should all gallbladder samples removed for gallstone be sent for the histopathological examination? To find out this answer of this question, I reviewed several articles, and I observed that there is a dilemma between a group of authors. Several authors have questioned the value of routine histopathology of all cholecystectomy specimen as because of low incidence of gallbladder cancer. Only 5.5 to 3% of the patient with polylithiasis will develop subsequently gallbladder cancer. The proponent of this group argue that this cancer is unlikely to develop in a gallbladder that seems normal and the patient do not possess any risk factor. And when a tumor is not visible under a microscope during a gallbladder examination, it is typically in its early stage, and straightforward cholecystectomy is the main way of treatment. In this regard, a systematic review and meta-analysis was done in Amsterdam, Netherlands, to determine whether the selective histopathological examination is safe in terms of maximum rate of incidental gallbladder cancer. Here, the 73 study, which included 232,155 patients, clinical consequence of the truly incidental gallbladder cancer were assessed. Analysis showed that at least half of the gallbladder cancer not detected during the surgeon's examination were early stage of cancer, and there was no clinical consequences. The study concluded that selective histopathological examination of the gallbladder after initial macroscopic assessment by the surgeon seems safe and could reduce cost. Another group of authors who support routine evaluation concurred that macroscopic examination of the specimen can readily overlook the early stage cancer. The reason for such a dispute is straightforward, as because the gallbladder dysplasia may be missed through the inadequate sampling, since people with gallbladder dysplasia may progress to cancer and are more likely to develop cancer at other site in the biliary tract even after gallbladder is removed. One of the study done by the Royal College of Pathologists and recommend that it is mandatory to submit all gallbladder specimens for histopathological examination, as because many significant pathology can present with normal morphological appearance like dysplasia, incidental gallbladder cancer. Not only that, the histopathological examination also confirm the final diagnosis, justify the operative procedure, and document any pathology of the gallbladder which also have some judicial importance. So this gallbladder is almost normal in gross examination, but in a histopathological examination there is a presence of the low-grade dysplasia in the lining epithelium. So in conclusion, I can say that the majority of the incidental gallbladder cancer expected to be at early stage of the disease. There are different opinions in the literature about the examination of the gallbladder specimens. Routine histopathological examination is necessary for all gallbladder specimens because it is only possible to detect the disease at its treatable early stage. Thank you all. Thank you for patience hearing.
So there were two questions assigned for this session. Number one is histology of the gallbladder. So gallbladder is different from rest of the intestine by having a very thin wall which is comprised of 4 layers, mucosa and lamina propria, and the second layer which is comprised of muscle layer, and the muscle layer is also very peculiar in the gallbladder that not continuous bundles are present as are present in the rest of the intestine. They are discontinuous bundles from where the Rokitansky-Aschoff sinuses invaginate into the third layer, and the third layer is also very peculiar by having a greater density of lymphatics and blood vessels. So the tumors of the gallbladder have high propensity and they have a high opportunity to go to the regional lymph nodes. And then the fourth layer is the serosa layer, which we all know that is lacking towards the hepatic side. So all the tumors of the gallbladder which reaches up to the third layer, that is the perimuscular connective tissue layer, they directly spread to the interlobular hepatic tissue and they have a poor prognosis. Then the another thing is Rokitansky-Aschoff sinuses, which are actually the epithelial invaginations which spread to invaginate from the discontinuous muscle layer to the third layer. So it is very important on the part of pathologists to differentiate between the carcinoma in situ or dysplasia which are developing in the sinuses from the invasive carcinoma, because for carcinoma in situ and dysplasia of Rokitansky-Aschoff sinuses, we all know that the simple cholecystectomy is curative surgery, while if it is an invasive carcinoma which is spreading up to the third layer, then radical surgery is mandatory. So this way histology of the gallbladder is different from rest of the intestine. And the second question was, should all the gallbladders removed for the gallstones be sampled or not? So the answer conclusively is yes, they should be sampled, and there are two reasons for that. Number one, that 80 to 90% of the gallbladder carcinomas are associated with the gallstones, and it depends upon the type of gallstones and also upon the length of duration that the stone has been into the gallbladder before developing the cancer. So all the gallbladder cancers, all the gallbladders removed for the stones should be sampled, and how it should be sampled and how the stone causes dysplasia and carcinoma sequence. So by the continuous irritation of the mucosa, it causes mucosal atrophy, followed by metaplasia, intestinal metaplasia, followed by dysplasia, and then carcinoma. So this is the sequence. Now the second reason why it should be sampled is that the biliary intraepithelial neoplasia, which is a term introduced by WHO in 2010, they comprises of two types, low grade and high grade. The high grade dysplasias or carcinoma in situ, they have a very high propensity to develop into invasive carcinomas. So now the question is, how many more sections should be examined? So we collectively have, I think, discussed in all the sessions that 6 additional sessions are sufficient to exclude or to diagnose invasive carcinoma, plus additional sections from any abnormally looking or abnormally felt areas. So with this I conclude the session if there are no further comments.
The group which is addressing these questions, two things have to be highlighted. One is, if the gallbladder grossly looks normal, are 3 sections, which is the standard routine today, good enough to detect or not to miss a lesion in the rest of the gallbladder?
No sir, additional 6 sections are mandatory if it is normal looking. If it is abnormal looking, then the entire gallbladder
Abnormal is fine. Abnormal means you will do a good mapping. We are talking of a grossly normal looking gallbladder. What should be the recommended number of sections?
3 as per protocol plus 6 additional. If
that-
dysplasia is seen.
That point has to come out, what Dr. Prashant Mathur also said earlier, the recommendations which are going to come, because again the same point that these gallbladders will be looked at not in institutions. These gallbladders will be looked at periphery, the practicing pathologist. So we have to give practical, easily implementable guidelines so that cost doesn't go very high on one
Yes,
side,
sir.
on the other side we don't miss.
Yes, sir. Keeping both the points into consideration, financial aspect also, and not missing lesions also. I think the 6 sections are sufficient enough to exclude or to diagnose invasive carcinoma in cases of
So
dysplasia.
the pathology members of this group will have to give little more details which can be understood by the routine practicing pathologist, that how and from where these sections are to be taken. That is one. Second point is, from your point of view, picking up a dysplasia or a bilin or a carcinoma in situ is all right, because that is the documentation. That is for understanding the disease. But from the patient's point of view, from a clinician's point of view, anything up to T1A doesn't matter, because the treatment has already been done, gallbladder has been removed. What is important is T1B and beyond. So you will have to highlight what are the chances that a T1B or a T2 lesion can be missed on gross examination, because the other group of papers which say selective histological examination, they say if the gallbladder looks grossly normal, there is no need to do it.
So as far as T1B lesion is concerned, the lesion, the disease is coming up to the lamina propria, which is a part of mucosa. So gallbladder lacks submucosa and muscularis mucosa layer.
Muscularis propria.
Muscularis mucosa, not propria. Propria is there, but it is in the discontinuous form. Muscularis mucosa is missing in the gallbladder, and submucosa is also not there. So that is why the thickness of the wall is
Muscle.
T1B is up to the muscle. Okay, okay,
Muscularis.
fine, fine.
So
fine.
what the group has to say, that if we follow selective histological examination, that means we don't subject the grossly normal looking gallbladder to histology, what are the chances that a T1B or a T2 lesion will be missed? If those chances are very small, then the other group is right. But if the chances are significant, then what we are saying, that all gallbladders must be subjected to histology, is correct.
So that depends upon where the patients are. Like if we are examining the patients in the high risk area, then of course we'll be.
Sir, grossly.
Yes, sir. In high risk area, there are pretty high chances to miss the lesion.
Sir, as you have highlighted, in my presentation I made it into 2 ways. What are the points if selective histology is done? What are the extent we can miss the neoplastic lesions? And accordingly, there is no doubt we have to take a longitudinal section 3+1 protocol. But if we identify any neoplastic lesion, as has been highlighted by me and other speakers also, then we have to take additional section. But making it a mandatory to process the whole gallbladder straight on, it will increase the cost substantially.
Yes, I
so
also
that's
second.
why I make it like that. It is up to the institution and up to the pathologist's discretion and the group's discretion. If they can afford, the patient can afford, then only that approach can be done.
Yes, I
but
also
additional
second.
section is a must and must.
Yes, I also second Dr. Prasenjit, but then there is a very important point. Like the pathologist, it's moral duty of the pathologist to differentiate between the reactive atypia and between the dysplasia. So there are certain markers also like P53, P16, but this is, I know they don't, yeah. So in case you find any atypia or dysplasia, it is mandatory to give additional sections.
According to me, if you have given the sections before now of abnormal gallbladder and you are getting T1A, then how many sections more should we take to get it so that the chances of getting T2 or T1B is there? That is what the sir is asking, the percentage of sections,
This is
how
the
many
easy
we have to
thing.
take.
You have taken samples from a certain area. The specimen is with you. After you have detected carcinoma T1A in those
Yes.
sections, that means the tumor is there. You have taken from the center of the lesion, and you have to sample the adjacent area, whichever is left there and which is looking abnormal, to see if there is any deeper part or invasive part of the tumor which is left or not.
So are there any number of sections which we have to take,
Yeah,
or
that,
the
that we have
mapping?
already said. If there is a T1A lesion, invasive lesion, then it is better if you can cannot afford the whole gallbladder mapping, take six sections. But as Dr. Puja said, sometimes you have to take more sections. It all depends on your protocol. But minimum, whatever we are talking today is about the minimum which should be taken as a must.
One more question I want to ask. You mentioned about the distance of cystic duct margin from the gallbladder. But many a times you know that grossly we are not able to identify the tumor size. So how can we give the distance of the cystic duct margin from the gallbladder?
So whenever we are able to identify the tumor mass, then only we can give. That is for sure. And there is no such validated study also, like a colorectal carcinoma, the circumferential margin, there is a implication of the measurement. But I think always distance from the clear margin is important, and we should do that practice. So that was my personal interpretation.
So for that, don't you think that we have to give a radial section for that, not the shaved one, so that we can identify how much is the distance where it is clear?
The radial section we only take when we can identify the tumor for definite, and it is very close to the tumor. Otherwise, if you can identify, or if you are not identifying any mass, you are taking random sample, or you have identified the tumor mass which is sitting in the fundus, then circumferential margin is enough.
Even if you are giving random sections, they are marked beforehand in the grossing, that from where the section has been given, so you know that what is the limit of the tumor and what is the distance from the system.
My question is straightforward. It will have just an answer in yes or no. So it has arisen from what Monica said in the last time when she was chairing the session. If we have to take multiple sessions from the gallbladder and we feel that the small lesion can be missed, is it feasible and practical for the whole gallbladder if we take an imprint of the entire mucosa? So if it can be malignant?
No, the answer is straight away no, because many of lesions beyond the mucosa are missed.
True. And see, there are limitations of frozen section. So if we can grade that, histopathology is gold standard. Frozen section is dependable, but cross smear and touch smear we don't rely on, because it is a by chance you can identify something.
Thank you very much, chairpersons and speaker, for enlightening on this important topic.